So thank you, Hassan. Can everybody see the slides?
Yeah, very well.
Perfect.
Okay. So these are my disclosures. So Hassan actually brought up this very interesting topic of neoadjuvant therapy in breast cancer, and actually, it's actually a very relevant paradigm because it actually is in breast cancer where neoadjuvant therapy, that is therapy that is given before surgery, actually started. So the conventional approach to systemic therapy given after the removal of high-risk disease is surgery followed by post-operative care, whether this be adjuvant chemotherapy, hormonal therapy, or these days even immunotherapy. But in breast cancer, the idea was to try and give some element of this treatment before surgery to both reduce the risk, the size of the tumor, and improve what is termed operability. That is, make the cancer easier to resect, improve what is known as the breast to tumor ratio, but also to potentially increase the likelihood of the drug working. And there are now several mechanistic reasons why this might be the case. What we know is, and this is some very elegant work from an investigator in Australia, and these are mice that are given immunotherapy cocktails of various kinds. This happens to be PD-1 or the PD-1 CD137 agonist combination. The short version is that when you give the mice immune therapy before surgery, they do a lot better, that is this slide, compared to when you give the same drug just after surgery. So this is a huge sort of change in the way in which people think, in that previously it was thought that giving some people immune therapy before surgery would just improve, maybe resensitize the tumor and make operability better. But here we have, for the first time, some very elegant data showing that not only could you improve the resectability, but it could actually make the drug work better depending on when you give the immune therapy. And this is now a paradigm that has been taken forward in breast cancer and has resulted in, firstly, the approval of this as being the standard of care in breast cancer, but also a drug approval endpoint in breast cancer. So how does this change what we do in melanoma? Well, high-risk resectable melanoma, that is patients with lymph nodes that are palpable, the patients who have cancers that were originally stage 1 or stage 2, who then relapse with a lymph node in the armpit or in the neck or in the groin and have palpable lymph node disease, comprise about 7% of all incident melanoma on an annual basis. And the key thing to understand about these patients is that they have a high risk of the cancer coming back even before you start the adjuvant therapy. In fact, in these studies that were done, these are the studies that got adjuvant Nivolumab, that's Checkmate 238, adjuvant pembrolizumab, that's Keynote 054, and adjuvant targeted therapy with dabrafenib and trametinib, that's CombiAd, approved. The key thing to understand is that in these patients, in these studies, a quarter of the patients who enrolled actually could not even go on to receive either one of the control arms or the investigational arms because they failed, because their cancer actually came back before they started. So the point is that these high-risk patients with palpable lymph nodes, actually comprise the majority of patients who don't even get to start the adjuvant therapy because they screen fail for these sometimes before they start. And 2, they also comprise the majority of patients who actually fail adjuvant therapy even when it's given quickly. So the short version is that this is a very, very relevant paradigm in melanoma because even when you do things well, the survival remains poor. And we better need to understand why certain drugs work and certain drugs don't work. And therefore, giving people treatment before surgery, doing the surgery, allows us to understand why drugs work a little better. There have been lots of trials that have been done in this space in the last couple of years. I've summarized a variety of these over here. And the key thing to understand is that the readout that you've seen from some of these, is basically this column here on the right, which is the PathCR column. That is the proportion of patients who have high killing of cancer, meaning a pathologic near complete or complete response, ranging from 20% with one dose of a single PD-1 inhibitor, pembrolizumab, to up to about 60% with patients with combination targeted therapy. And with Ipi-Nivo, that is the Opdivo with Yervoy, can be as high as 45%. But the key thing here is that these numbers can be improved, and that's what the investigators that are working here are trying to do that. And we know that when you give immune therapy and targeted therapy, this works really well in the setting that in this neoadjuvant setting. They both work really well. They can cause high degrees of pathologic response. But in particular with immune therapy, the relapse-free survival appears to be particularly good for patients who have a very, very good complete or near complete response. So what we did was at the University of Pittsburgh, we wanted to try, and we've had a long history of developing these trials. We have been working in Hassan's lab now with TLR9 agonists for almost 10 to 15 years, trying to figure out how to make these agents, which essentially act on the immune system, to magnify the responses to immune therapy by presenting antigens from the cancer to the immune cells, how to try and get these agents to work in combination with immune checkpoint inhibitors to magnify immune responses. So some of you on this call have actually participated in this clinical trial, and this trial actually started 2 years ago. The first patient was actually enrolled in June of 2018. And in this trial, patients get with high-risk melanoma that is potentially resectable, so patients with 1, 2, or 3 lymph nodes, or patients with in-transit or satellite lesions that have lesions that we can either inject and biopsy, undergo 2 drugs. The first is an injection of this CMP-001 or TLR9 agonist, and it's given along with the immune therapy, Nivolumab or Opdivo, for a total of 7 weeks before they get scans done. And then they continue to receive a little bit more of the drug after surgery. And what we're really trying to see is how much of the time, what proportion of patients have pathologic response? That is, what proportion of patients have complete eradication or near complete eradication of tumor? And secondarily, is this response associated with durable relapse-free survival? So we have at this point in time enrolled a couple of patients, approximately 22 patients, 26 patients as of this past week, the vast majority of whom are evaluable, and these are their statistics. And this is kind of what happens. When you give patients immune therapy as well as injected and intravenous, sometimes you see some major shrinkage, and this is a patient on the bottom. Sometimes you see some growth. But the key thing to understand is the CAT scans do not completely tell us the story of what is going on in the tumor of these patients. And for that, we need to really look into the tumor. But just by looking at the CAT scans alone, we see that this combination causes cancer shrinkage about 50% of the time. What is really impressive, however, is that this particular combination causes cancer eradication at the level of the tumor after 7 weeks, 71% of the time. So what's really, really amazing about this particular combination is that not only are we seeing complete eradication of tumor or near complete eradication of the tumor 71% of the time, but that this is happening without the major side effects that were seen with some of the other immune therapy combinations. So just to give you an idea as to how this stacks up compared to existing immune therapy combinations, from a couple of slides ago, we saw that immune therapy that is the best available standard treatment that we give to patients with advanced cancer causes pathologic complete response rates of 45%. Well, this causes pathologic complete response rates of 62%. And a major complete response that is complete eradication or near complete eradication about 70% of the time. These patients who have a great response have several features. One of the major things that we see is that in patients who've done really well, this immune therapy combination causes a dramatic increase of CD8 T cells. These are the immune cells that are present to some extent within the tumor that are magnified, as you can see here in the bottom right, in patients who receive this combination. And in some patients who unfortunately do not respond, we see that the immune therapy combination actually doesn't work. But this is the value of this particular approach. You can see very quickly after just 8 weeks who's going to do well. Who's going to do well. what we've also shown is that the vast majority of people who've done really, really, really well have durable relapse-free survival. In fact, the patients who have had a complete response, we've only had one patient who's actually relapsed, and that patient relapsed in an area that was outside of the body. So where is this going next? Well, this combination is now being studied further internally with an imaging biomarker sub-study that some patients are enrolling on. And it's also being taken through the cooperative groups in a randomized study that is being led by myself and Dr. Tarhini at Moffitt under the leadership of Dr. Kirkwood. This is also a key marquee study of the current SPORE proposal, and is the correlative science that I've just shown you is being done both by myself and the work of Dr. Zoro, who actually has had a long history of being involved in the TLR9 development process. We're also looking at this particular setting as being a great way to study other drugs as listed here, including TIM3 blockade as well as oncolytic viruses. So in conclusion, neoadjuvant therapy and target neoadjuvant therapy with either immune therapy or targeted therapy is very active in highly resectable melanoma that is of stage 3, B, C, or D substages, and is associated with a high PCR rate. Having this complete eradication of tumor clearly improves both your relapse-free survival and overall survival. However, unlike breast cancer, this endpoint is not a regulatory endpoint, at least for now, and though that may change. We are very interested in moving this forward. And in order to make drugs available to more patients more quickly, we really need to start thinking about whether it's possible to try and do more studies more quickly in fewer patients. And that's where neoadjuvant studies may actually be a game changer. But in order to do that, we need to go through a couple of steps, and that's what the melanoma community is working through at this time. So even though right now, this is not a registrational strategy, this may be a registrational strategy in the future. What can you do? So if you have a patient, family member, or if you are a patient with stage 3 melanoma, that is, if you know that you have a positive lymph node, or the lymph node comes back after you've had early stage disease, please ask your surgeons, please ask your dermatologist, please ask your Mohs surgeon or your oncologist about neoadjuvant trials. You don't have to enroll in ours, but you should ask them whether you're a candidate. There are many, many investigator-initiated trials, both in Pittsburgh. There's also a national cooperative group trial that is testing neoadjuvant versus adjuvant therapy through SWOG. And as I just told you, the ECOG cooperative group led by Dr. Kirkwood will have 2 neoadjuvant studies, one of a targeted therapy and one of immune therapy in the next couple of months. If you're a patient advocate, please engage with MRA and AIM about neoadjuvant trials. In fact, the AIM and the MRA websites do list neoadjuvant trial as a possible treatment option for stage 3 disease. But it's worthwhile for you to ask your physicians and your physicians about this, and as well as the patient advocacy groups. And so with that, I'll thank you, and I'll stop and answer any questions you might have.